There you go. Got to click, got it. Probably tomorrow sometime we'll be sending a follow-up email to everybody who attended with the recording and also with the slide decks and the call to action. So you don't need to take copious notes or anything. You'll get the slide deck later. As I mentioned, the hosts for tonight are Indivisible St. Paul and Edina Indivisible. We are both volunteer-led chapters of the Indivisible movement, and you can learn more about our efforts and join our work if you would like by visiting our websites or Facebook pages. Our first guest is Rose Roach, who is the National Coordinator for the Labor Campaign for Single Payer and the Board Chair of Healthcare for All Minnesota, which is promoting high-quality healthcare for all Minnesotans. And our second guest is Senator Liz Boldon, who is a registered nurse and state senator representing Senate District 25, the Rochester area, in the Minnesota Senate. She is the Assistant Majority Leader and serves on the Health and Human Services Committee. And we'll hear from both of them in a few minutes. If you're new to Third Thursdays and wondering what this event is about, basically it's a speaker series that was started after the 2016 election, and on a not quite monthly basis, sometimes in person and sometimes online, we have information sessions that focus on issue advocacy, specifically around the Minnesota legislature. As today's is about healthcare, we've had sessions that are legislative wrap-ups or legislative previews or issues on specific topics such as climate and Line 3 over the last few years. Tonight, first of all, we promised to get you out of here by 8:15. And as I mentioned, we will be hearing from Rose Roach and Senator Boldon, and then we will follow up with about 15 minutes of Q&A, and then a wrap-up and a call to action, because we always like to leave you with something that you can do with the information later. So we should be done by 8:15. But what we're going to start with, in order to get everybody thinking about our healthcare system and hopefully not raise your blood pressure too much, because this can be a quite emotional topic, we're going to do an informal, low-tech poll. And we're asking you to put your answers in the chat as you think about the following questions. So, to start, number one, have you ever been denied, you or a family member or someone close to you? We can broaden it a little bit. Have you ever been denied critical care or coverage by your insurance company? Have you had to switch medications which your healthcare provider prescribed because your insurance company would not pay? Have you gone without or delayed healthcare because you didn't have the money to meet your deductible? Have you been overcharged for a healthcare service and had to fight to get the costs removed? Have you chosen lower quality private health insurance because the premiums were more affordable? Or have you lost your health insurance when you changed jobs? Have you gone to the emergency room because you didn't have insurance, or been told that the treatment plan recommended by your doctor isn't covered? Or number 9, some of the above or all of the above. And I'm sure some of us have more than one. So please put your answers in the chat and we'll just kind of browse through it a little bit. And maybe Julie or Jen, you can see anything interesting in the chat.
We're getting a lot of 9s so far.
A lot of 9s. Oh, yikes.
a lot A lot of nines.
A lot of itemization of just which ones.
Mhm.
Oh God, denied coverage for cancer surgery after the fact based on a false pre-existing condition. How tragic. How tragic.
Yes, switching multiple jobs and had no coverage at all. That's my big beef.
Yeah, I think it's not really a surprise because I think it's interesting to see all these questions put together in a list. And when you think about your own situation, yeah, as it appears, I guess in the chat, we all can relate to these items. I know for me, it's some of the above. It's not just one, maybe not all of the above, but yeah.
And thank you to those of you sharing short stories in relationship to this, because this is really what it's about. It can feel really abstract, but thank you for sharing your stories in the chat about just how directly and tragically this impacts people directly. And it's not a single generation issue. So.
Okay. So that leads us to why we're here today and why we're talking about healthcare now. We believe, as does Healthcare for All Minnesota and Senator Boldon and a lot of us, that healthcare is a human right. And it's past time for universal and high quality healthcare coverage for everybody. Healthcare costs will probably never be contained without a central payment system. And there have been years of attempts to control costs or increase quality and decrease disparities, but those attempts have mostly failed. And in the end, we want the ultimate authority for healthcare to be up to the doctors and their patients, healthcare providers and their patients. Not insurance companies. And so the system has to be changed in order to achieve affordable, accessible, and equitable healthcare. And today we're talking about mostly Minnesota, but I think most of us believe that across the country would like to see the same thing for everybody in the United States. So I am right now going to turn it over to Rose Roach, and she is going to share her presentation that is going to fill us in on more about why we're here and what we can look forward to in the future. So I'm going to stop sharing, and Rose, you can start sharing.
Wonderful. Thank you so much. Let me see if I can figure out how to get my presentation up. Always technology, right? Give me one moment. Here we go. That should work. All right. Everybody able to see that? Hopefully. So good evening, everyone, and greetings of health, fellow patients, right? Because we're all patients at some point in time. We all know that our current healthcare system is failing. It's failing patients and it's failing providers, but it is highly successful for those who seek to profit off of human suffering. And those profiteers are only increasing in number and power as they literally are buying up our entire healthcare system. We cannot allow this to continue. People's lives are at stake. Which is why Healthcare for All Minnesota is proposing a campaign to win the Minnesota Health Plan with transitional infrastructure building stepping stone legislation along the way that will help patients access care, begin to decrease costs for individuals, families, businesses, and government, and begin the removal of the privatizers from our public health programs. Before I talk about what such a campaign could look like and how you can get involved to help develop and implement that plan, I want to start this presentation with a bit of general information about the problem with our current healthcare marketplace, including some definitions, but also with an eye on our immediate work based on the passage of a number of really good bills that were wrapped into the final 2023 Omnibus Health Bill that was passed by the legislature this past spring and was signed into law by Governor Walz. So with that, Few definitions. So let's get grounded so we're all operating from the same premise here. Ultimately, as I noted, we want to see the Minnesota Health Plan passed and implemented. What do we mean by the Minnesota Health Plan? The Minnesota Health Plan is a single payer-like system that would be state-based for the state of Minnesota. Simply put, and I don't mean to read from the slides, but I'm going to in this case, so bear with me. You can see the 4 main principles here. It is a one-payer system that replaces several hundred insurance companies, ideally the other government programs, right? Let's consolidate. The single payer negotiates budgets for the state's 140 plus hospitals and other institutional providers. This is all defined under the law as it is presented, and it defines all of how the payment system would work. The single payer negotiates a uniform fee schedule for doctors, and the single payer also negotiates limits on drug prices with drug manufacturers. That's how we get streamlined payment system in order to get our head around the cost containment issue. And that is the number one barrier for everyone. It would seem is the cost barrier is the first hurdle to get over. But we have been dealing with something in this country and in this state called managed care. This is the favorite vehicle within the healthcare policy, and many economists in their world that they have completely really used to hog the spotlight when it comes to healthcare reform debate. The managed care is privatized multi-payer. It's a system that is founded on the theory that the problem with the cost of healthcare is related to 2 things: how we pay for it, using a fee-for-service payment system, meaning each procedure, treatment, et cetera, is paid using a fee for that particular service. And because we use fee-for-service, it incentivizes overuse. So we're overusing healthcare. In other words, doctors are greedy and they prescribe more healthcare than we need because it means more money in their pocket. None of that is true. None of it has been proven after decades of trying these various schemes, to say nothing of how insulting it is to our healthcare professionals. The tools that have been created by managed care, meaning the privatized companies whose main focus is on profits and not on patient care, include things like financial incentives, like bonuses that are paid to insurance company employees for denials, out-of-pocket costs. This is cost shifting to the patient through deductibles and copays and coinsurance. Utilization review. So this is an emphasis on reducing hospital stays, but sometimes discharging patients before they're ready to go home is not necessarily the right focus to have on this issue. Denial of care without review by an independent physician. So this is similar to sort of prior authorizations. It's intended to save money for the insurance company, but are extremely wasteful of the prescribing doctors and the staff's time. More business strategies that create yet another barrier for the patient that ends up causing them to just decide to give up. We've got the drug formularies. Everybody knows about how those work. Your drug is on it, it isn't on it, it goes on it, it comes off of it. They control that sort of willy-nilly. These are things that people need to be life-sustaining and life-saving, and there should be far more consistency and not controlled by an insurance company or by big pharma. Limited choice of providers or networks, all of this stuff, none of it has to do with healthcare. It has to do with business strategies, and these things can cause surprise billing. We see this happen all the time where patients suddenly get a bill that they weren't expecting. They thought they were in network, but the ER doctor isn't necessarily in network. So now all of a sudden you get a bill. That's not the way to set up a healthcare system. And these are all considered this value-based payment model stuff. It's integral to how our current public health programs are structured, and they must not be included in any way, shape, or form when we're designing, whether it's a public option or even looking at our current systems with MinCare and Minnesota Care and medical assistance. We've got to deprivatize them, and that really has to be job number 1 for us. So I will go on now to just show you one slide very quickly.
Hey, Rose,
Yes.
Rose, just one
Yes.
moment. Can you switch to slideshow view? Because we're seeing your notes
Oh, I don't
next
know
to-
why that is, because I'm
next to the-
surprised.
to the slide, and I don't think that's what you
Oh
intended.
gosh, no, it's not showing that way to me. So I don't, oh, how do I switch that? What if I do this? Did
There you
that do? Okay.
That's it.
All right.
Okay,
It
thank you.
sure. It switched it on me. So now I've just got to get a hold of here we go. All right. So I just have to be able to look at my notes. So let me go to the next slide. Sorry about that. This is sort of just meant as an impact slide, everyone. So I want to start with this graphic because it pretty clearly shows you how backwards everything is. The smaller yellow line on the bottom is actually the number of physicians that have entered our system between 1970 and 2019. And that sort of turquoise part of the graph reflects how many administrators and managers have entered. This is backwards, right? Duke University has around 900 hospital beds and 1,600 billing agents. That's not how we should structure a healthcare system. We want the providers to be the bulk of the folks that are operating within the system. That really warped graph sort of sets us up for the entire system, and it makes it clear why we must deprivatize our public health programs as job one. Let's start with the financial burden of administrative costs. Private insurance administrative costs eats up at a minimum 15% of Medicaid, Minnesota Care, and even in Medicare. State agency overhead doubles to 10% immediately under privatization. And of course, provider overhead also increases because they have to hire people to handle all the billing and the coding and everything that goes with that. An example is hospital administrative costs that many times are at least hovering around the 25% area. Those percentages add up to an enormous amount of healthcare dollars that are being wasted instead of used productively for patient care. There was specific data that has been done on overhead costs for state agencies pre-privatization, but post-privatization, it becomes a little bit harder for us to actually get that data. A good deal of what we know about the high cost of privatization is based on a health affairs study that was conducted in the 90s of overhead and administrative cost in Arizona's Medicaid program because they were the first state to privatize their Medicaid. The study compared their overhead costs to those of surrounding states that had not yet privatized their Medicaid program. And you can see here by the quote that back in the 1990s, the privatization medical assistance was in the beginning stages. Minnesota Care did not yet exist. There was a Minnesota Healthcare Access Commission that was formed and asked DHS DHS, by the way, is Department of Human Services here in Minnesota, what portion of total revenue or expenditures do they spend on administering medical assistance or Medicaid, which is medical assistance. As you can see, the response was, as quoted on the slide here, 4 to 5% of Minnesota's medical assistance program to the highs of over 20% once it became privatized. This becomes a real problem and why it's so important for DHS to really get a handle on exactly what we're paying in these administrative fees for privatization. Value-based payment models, as I said, an instrument of managed care, they just don't work. The schemes have done nothing to control costs, to improve quality, or to decrease health disparities because they're based on these business strategies and not on actual healthcare strategies. Even those who support this nonsense have to admit, as you can see from the slide, that they actually don't work. It's time to move on from incremental steps that further entrench the private medical industrial complex and instead refocus our efforts at rebuilding our public health program infrastructure, expanding it, and eventually opening it up and bringing it, opening it up for all of us to be part of it. And I don't want us to forget the impact that managed care ideology has had on the merger mania that we've been experiencing here in Minnesota in particular, and its impact on cost. Minnesota consolidation has played a major role in our average healthcare costs, moving us from the category of average to becoming a high-cost state. Consolidation and merger frenzy has been a direct result of managed care, the prescribed treatment for the inaccurate diagnosis that we overuse healthcare because we pay it based on this fee-for-service model, and that is doing nothing to contain costs. And it is actually the exact opposite that is true. It is all driving prices up through added administrative costs, but also through market consolidation. It's important to understand what's been actually happening here with managed care. It's been infiltrating every segment of our healthcare system for the last 50 years, including Minnesota's public health programs. So to sum it up, as you can see here, there's almost no public health programs left anymore. They've all been privatized on some level, and it's really important that we move forward from that. And the legislature began that process here in 2023 with 5 studies that we're really putting an eye on that I think will help us sort of move the ball down the field when it comes to healthcare justice. Those 5 studies, one is a public option. There is a report due on February 1st, 2024 from the Department of Commerce and Human Services on different models of whether or not a public option is possible. And if it is, what would that look like? There's also a couple of directives that were given in the omnibus bill for 2 different bodies, creating a new body called the Center for Healthcare Affordability, which will live within the Minnesota Department of Health, and a health subcabinet that is going to finally put a focus and a lens on administrative waste and administrative costs. This will be very unique. We're one of the only states in the country that is doing this. This is going to be very helpful for us because I think we know where that waste is. Then we have also a directive for the Department of Human Services to actually bring back to the legislature no later than January 15th of 2026, a game plan, an implementation plan for how could we move forward with deprivatizing our public health programs. And of real importance and value to us at Healthcare for All Minnesota is the cost study of the Minnesota Health Plan. So this will take a look at, under a single payer system here in the state of Minnesota, how would that system compare to the current system and what would it cost? So we will finally know and have some data to see, is it cheaper? And if so, then we can start to peel the onion back and determine what that will mean for us as individuals and businesses and government and figure out how we fund that system going forward. So this is the last thing for me that I wanted to just point out, which is it's going to be really important as MDH and DHS start doing all of these in commerce, all of these various studies. We want to make sure that they're looking at per capita costs, because we have the irrefutable evidence that those healthcare costs are very high in the United States and Minnesota. So they need to look at them. They need to put a lens on administrative costs sooner rather than later. We know that they are at least 15%. Consolidation has to play into this. It drives prices up. So we have to consider that when we're looking at what are the cost drivers of our system and looking at that impact of managed care on cost and quality. Managed care doesn't manage care. Managed care manages money and claims. They do not manage care. So it's very important for us to look at all of that when considering these reports that are going to be coming forward to the legislature. And with that, I think I'm turning it over to Senator Boldon to talk about some of the terrific work that she did this session.
Well, good evening. Thank you so much. I'm so grateful to be here with you all tonight. I'll just start with a brief introduction. And I thank you to Rose. I learn something every time I hear her speak and I'm in these spaces with her. So I so appreciate her and all of her work. So I, as was shared, I serve in the Minnesota Senate. I represent District 25, which is Rochester. I serve on the Health and Human Services Committee. Prior to my role in the Senate, I served 1 term in the House, and I served on HHS in the House as well. I am an assistant majority leader, and I am one of the co-chairs of the Minnesota Health Plan Caucus. And so certainly that is extremely important to me that we move forward in that direction and get to a place where we can pass and enact the Minnesota Health Plan. And in my work and life outside of the legislature, I'm a registered nurse. And so I believe, as do probably everyone on this call, that healthcare is a human right. All of us, everyone on this call, everyone across Minnesota deserves access to quality, affordable care. And that is possible, that we can get to that point. We do not have that right now. Even, in my district, in our backyard is some of the arguably the best medical care in the world. It is out of reach for many, many people. And I see that both in my work as a nurse. I work in a hospital. I take care of patients. I hear from patients nearly, if not every shift, almost every shift, hear from patients their worry about the cost of their hospital stay that's happening right now. Their worry about what's going to happen when they go home. Do they have the resources that they need? Are they ready to go home? Do they have those resources? Or concerns about that they didn't have primary care, or they didn't have preventative care, and that's what landed them in the hospital. Or any other number of the issues that we talked about in that first slide. And so I have seen that up close, for the last 20 years. I will say it certainly has gotten worse. I mean, I didn't used to, 10, 15, 20 years ago, I did not hear that from my patients every day. And now I absolutely do. And the other aspect or the other sort of perspective I have on this is as a family member. My son was in a severe motorcycle accident about 1.5 years ago and ended up with significant medical needs after that. And so on a nearly daily basis, I'm interacting with the healthcare system for him, trying to navigate getting him the care that he needs. Literally today, I was on the phone for over an hour because I learned that he has claims denied from his insurance company back to August. And so not sure why they were denied, but, made phone calls to different numbers without the ability to speak to a person, without the ability to leave a message. As I was venting to someone about this today, I said, we couldn't make the system more difficult for people if we tried. And that is so true in so many ways. And I know that I am not alone in these experiences. I know that probably many of you have similar stories. Just this past weekend, Senator Erin Murphy and I were in Albert Lea, Minnesota, hearing as sort of a listening session around healthcare, hearing stories from folks. And, consolidation is a story of what happened in their community. The hospitals were consolidated and then shut down. And so there's a huge gaps in care there, and hearing the stories from folks about, what that means in their lives and the challenges that presents to them to getting the care that they need. One woman told a story of, she had a mammogram, was told that she, needed follow-up, that she found a lump. And it was over 3 weeks that she could get an appointment to see anybody about it. And that was because she went somewhere else outside of her community, and was told at that time that those 3 weeks, that gap, because it was such an aggressive cancer, cost her dearly. It cost time in her life that she can't get back. And that's, there are stories upon stories upon stories. And I just want to reiterate what was mentioned at the beginning of the session of the importance of those stories. That is really necessary as we build a movement, and that's what's going to take to change our system. I mean, this is a big lift. We don't want to tinker around the edges or tweak this little thing or just make a little change here. We need to build an entirely different system, one that is not focused on profits, because that is what we have now, and it's profits for CEOs and executives and insurance companies, and a few, to really a system that is based around care and ensuring that everyone has the care that they need. And so that is going to take a lot of work and a lot of public pressure, honestly. So I'm grateful for the partnership of allies and advocates and Minnesotans across the state who are really speaking up and demanding that we deserve better. And how long are we going to put up with a system that does not work for us? So I appreciate the willingness to share those stories, because it is so meaningful and so impactful. I'm very excited about the studies that we passed this session. I think that is going to be critical moving forward. The Minnesota Health Plan feasibility study is really important because it will really be the first time that we are looking at the true cost and compared to our current system. Before there's we hear about, oh, it's so expensive, it's so expensive. But if you don't look at the big picture, if you look at the big picture and the cost savings that will also come along with that, you have to have sort of both sides of that ledger. And so that study will do that. And the other thing I just really want to highlight is the study around the public option. And we'll be getting a report around that at the first of next year, February, I believe. And I just want to say how critically important that will be that we get that right. And the public option isn't the end all be all. It's not the end point of where we need to get, but it is a step in that direction. And we absolutely need to get that right to start building the public infrastructure so we can get to the Minnesota Health Plan. It's like the next step on that path. And just transparently, I have some concern about there's some work to do to be sure that we get that right. There are, the department is looking at options for, what that public option will look like. And there's sort of, I think there's three options. One is what is a truly public system where it's DHS runs the program. It's a public system. Another option is that we partner with a private insurance company and they build a new system. Or we partner with a private health insurance company and sort of subsidize current private plans. And so only one of those options really gets us to the next step to the Minnesota Health Plan. And so it is critical that we have accurate information and really start building that public infrastructure. So I am continuing to work with my colleagues to be sure that the department is using accurate assumptions and getting us accurate information to really tell the story of what that public option would look like, so we can ensure that we end up with a true public option. Maybe I've just talked a whole lot, so I will maybe pause there and look forward to questions. But I just am grateful for everybody who is in the fight, because that's what it will be. But it is absolutely possible to really build that system that is focused around care for everybody. And I look forward to doing that.
Thanks so much for those comments, Senator Boldon. We're going to come back to a couple of the things that you brought forward. And at this point, I think what I'm going to ask people to do is in your Zoom meeting, so that we can see these folks as they're sharing their responses to your questions, go up to the view and select speaker. That way, as Senator Boldon and Rose respond, you'll be able to see them large and in life. So, Jen, I'm gonna reach out to you. Have you seen any specific questions come up in the chat? Because I've gotten a couple privately.
One that's Senator Boldon answered was throwing this out to anyone. How is the study being funded? And Senator, do you want to be more specific about where that money is coming from? And please.
Sorry, my audio cut out for just a second. Did you ask me to clarify my answer there? Great. Yes. So in the legislation paired with the legislation to direct the study, we allocated funds with those studies as well. So it comes out of the it's in the state budget to fund those studies.
Great, thank you. I've got a question here too. So, you talked about it being a heavy lift. And this question really kind of talks to, all right, there are going to be so many stakeholders on this. And frankly, a lot of opponents, lobbyists, large, Mayo, legislators, and obviously a lot of activists who are involved in this movement. So who drives, like, you know, the sausage making of actually shaping the policy that would come out of these studies?
I can speak to that, and I imagine Rose has thoughts about that as well. I think just to say that, you know, I think that's right. It is going to be a big lift. There are going to be lots of stakeholders, and there's going to be lots of opposition. I mean, let's just be real clear about that. We are talking about, you know, these big corporations who are making billions of dollars in profit, billions with a B. And so they are not going to go quietly to, you know, to stop, you know, making billions of dollars in profit, because we are redesigning a system that focuses on care rather than profits. And so, you know, just to frame it, that there will be opposition, and that's why it's so important for advocacy. And so who drives legislation? You know, that comes different ways. So certainly, you know, us in the under the dome in the legislature, there's in the Senate and the House, we are the ones who we're at the end of the line, right? Like, we are the last stop. We cast the votes. That's the last stop. And certainly there's, you know, those conversations, and we bring our perspectives, and you know, what leadership in the Senate and the House makes decisions about priorities. And I want to say really clearly that, you know, we serve our constituents. So Minnesotans are the ones who drive the priorities and the work. And if we think about, I've been thinking a lot about paid family and medical leave, and you know, that we passed this last session, and how that also was a big lift, huge deal with huge impacts. And how did we do that? It was because there was a coalition. It was that partnership inside outside. There were certainly those of us in the legislature who were champions of this and said, yes, we absolutely have to get this done. This is really important to me. And there was a huge coalition of folks on the outside, advocates and Minnesotans, who showed up at rallies and made phone calls and sent emails, and advocated to those who represent them to say, we need this. I expect you to get this done. This is what I want. And stories were so impactful in that fight as well. The stories of real people, what that means in their lives. I think there are a lot of parallels between that fight and this fight. And so it's all of you who, you know, and more, who really drive that policy until it, you know, there's a tipping point until it becomes more controversial to not do it than to do it. And we have to keep building to that tipping point.
Great, thank you. Rose, did you have anything additional to kind of add to that question?
You know, the only thing I would add, I mean, it's exactly right that we can help drive this policy. Policy can get wonkish, right? And sometimes when you're doing movement work is a lot about organizing, right? And getting people engaged. And sometimes that's hard to do if you get like too policy deep, and people are like, what does that mean? I'm not quite sure. So one of our tasks is to figure out how to talk about these things pretty straightforward, help people see why it matters to them and to their family, right? You got to meet people where they're at. This is all about organizing. And then it is bringing them all together to really put that pressure on the legislature and make sure that the legislature are asking the questions we are raising, right? And saying, wait a minute, why didn't you look at this? Or did you ask this particular question? If you didn't, we want you to go back and ask it. So we can have an enormous impact on that as the constituents, as the patients ourselves. We just have to go ahead and come together, and not everybody has to do it at the same time in the same way. There's room for all of us. Some of us like that heavy policy stuff. Some of us would rather be just, you know, talking to one another about how healthcare is not working very well for us and our families. That's okay too. Let's find our strengths and let's play on them and let's use them to build the movement and push the legislature and those seated in power to represent us and not those big corporations.
Great. You know, that's why it's so cool. We have 57 people on this call tonight, and everybody's interested. So thanks so much for kind of framing that in a way that says we have to lift all of our voices in support of the work that's happening. Jen, I'm gonna, do you have a question keyed up? And then I'd ask you to come back to me. I've got one in the private too. Go ahead, Jen.
We've got a lot of good questions coming through, and Kathy P brought up one that I think a lot of people have been thinking about. I certainly have, with friends in Canada. Is anyone looking at the Canadian system administered province by province by the provincial governments and is partnership with medical providers? So we know how are people looking at other countries for the better medical systems? Is any of that happening?
Well, I'll take a crack first, and then Senator, I think you can probably add to this, but yeah, I mean, we have this idea of American exceptionalism, right? And the funny part about that, not so funny, is that our life expectancy in this country has actually gone down over the last 3 years. The richest country in the world, we're paying the most money for healthcare, and our healthcare outcomes are abysmal. To say nothing of, and somebody talked about health disparities, those continue to get larger and larger. They're not shrinking. So can we learn from other countries? I'm not sure there's such a thing as a perfect healthcare system, because we're human. And it's hard to figure out exactly what that is, but we could do a heck of a lot better than we're doing now. We can look at the Canadian system, which did develop right above us in Saskatchewan first. That's where Tommy Douglas was actually a premier up there before he became prime minister of all of Canada. They started there, and then their large national government said, hey, that looks like a good idea. Tell you what, we'll match your funding dollar for dollar if you can really show that this is helping people get healthcare affordably and accessibly. Now, that doesn't mean they aren't struggling. I spent some time with Canadian nurses. We went through their system. I even met one of the original framers of their system in Saskatchewan that started the whole thing. He worked directly with Tommy Douglas. And I'll tell you, they say we've got some flaws. We need to do better too. We've got to fix it. There are holes in our system, but it's all about prioritizing budgets. It's all about resources. So we can learn from the Canadian system, from the United Kingdom system, from Australia, from Thailand. There are a myriad of systems that we can look at. We can still be exceptional as Americans, design our own, but we have to do something better than what we're doing right now. At the bottom line, no one should have to worry about going to the doctor when they're not feeling good, simply because they're afraid they can't afford it or will go bankrupt.
Yeah, I think that's exactly right. I don't have a whole lot to add to that, other than just to say, I mean, the short answer is yes. I mean, we should be looking at other countries. Not that exactly what they're doing should be exactly what we are doing, but we have lots of room to learn. And clearly, what we can say for sure is that what we are doing is not working. And so we should absolutely be looking at other places. In the United States, the number one reason for bankruptcy is medical debt. That is wrong, and again, it doesn't have to be that way. And so I also just want to say I just saw a question in the chat about is it speaking of the way it's spread from province to province in Canada, should we be fighting for state by state or federal Medicare for all? And the answer is yes, and like we should be advocating and working towards all of it. What we can't do is wait, in Minnesota, wait for it to happen at the federal level. We can't just sit here and wait and hope it gets done there, or even just sit here and wait and work to get it done there. It has to be both. We need to be working on it here as well.
Great, thank you. Jen, have you found another one? You might be muted, Jen.
I'm a beginner. Why don't you ask your other question? I know that was a key thing, and I'll look. I'm kind of pulling together a couple things because.
Yeah, sure. Okay. So one of the questions is, after these studies come in, and you guys have already talked a little bit, but it's basically asking, how can we ensure that like the bills being put forward are really proposing progress versus incremental steps that are more of a distraction than actually helping us to move forward. And maybe we'll start with Senator Boldon first, and then we'll toggle back to Rose.
Yeah, happy to chat about this. I have a couple of thoughts on this. One is, I mean, certainly, we want to keep eyes on the prize, like Minnesota Health Plan, single payer, whatever the name ends up being is the ultimate goal. That is where we need to land and where we need to end up. And that's not going to pass next legislative session. Like, we can't go from where we are now to the Minnesota Health Plan, like in one leap. So, I hear concern about like incrementalism, and to a point I agree with that. Like, like I said, we have to stop, like, we can't just tinker around the edges and like just tweak here and tweak there. And there are going to be multiple steps to get between where we are now and the Minnesota Health Plan. One of those, I think, is the public option and getting that right and standing that up. Another one, which will happen sooner rather than later, is, as Rose mentioned, deprivatizing deprivatizing our public programs. I think that could happen relatively soon. And so I will say the Minnesota Health Plan Caucus, which is has been relaunched and reinvigorated, which right now is just legislators, but we will be branching out to partner with advocates as well. This is like top on our priority list, is mapping out what those steps look like. So we have a clear plan and a clear path of what those steps are. So we are sure that we are moving in the direction, and the end point is the Minnesota Health Plan.
Great. So we should just look for legislation authored by you guys. Rose, did you have something else to add?
I do. I think that, as a movement, we have been a little bit like scared of incrementalism, and rightfully so, because the incrementalism that we've been experiencing has further entrenched the medical industrial complex. It is given more money and power, right, to insurance companies and to big pharma, big hospital systems. But it's okay. I'm telling you, we are, it's exactly what Senator Boldon said. We're not going to get there anytime real soon. So every one of the bills, whether it's the state bill or whether it's federal bills, they have a whole section on a transition. Why should we wait to pass the big bill to begin the transition? We can start transitioning now. So let's take those pieces out of the bill and let's start implementing them one step at a time, so it will be an easy move for us, right, to just go into that Minnesota Health Plan or Medicare for All. Last thing I'll say, these are very simple, straightforward, 5 criteria that we look at when we're looking at healthcare reform. Does it strengthen the social insurance model? Does it decommodify healthcare? Does it move us closer to Medicare for All or the Minnesota Health Plan? Does it help us build power and bring more allies into this movement? And finally, does it help to weaken and divide the medical industrial complex and their allies? Those are some really good, just standard criteria we can be thinking about as we get throwing all these different types of possible, reform legislation.
Great. Thank you. Jen, can I come back to you?
Yeah, this, Rose, what you just mentioned, there's a question that's just about that. So this comes from Liz, and her question is, my social circle is very liberal, but when I bring up single payer or MHP, they dismiss me saying that'll never happen. I shut down. Any tips on how to handle this? I'd like to educate them on this subject.
I think that one of the things, one of the roles I'm in is as the national coordinator for the labor campaign for single payer. There are a lot of really big national unions that absolutely support Medicare for all. And when I've been doing some outreach lately, a lot of those leaders have been like, yeah, we're on board. No problem. We know that's where we've got to get there, but we're just, I mean, we don't have the conditions right now to make it happen. So what are we doing? What are we supposed to do? So one of the things that I've started to do in talking with people is really pointing out that, you know, the current system is just not sustainable. It's not sustainable economically for us as an economic system, and certainly not as individuals, and it's not morally sustainable. So you're right, we're not there yet. So let's talk about those things I said earlier. Let's talk about what could we start doing now that really helps patients, helps families, you know, helps government and businesses with what they're facing right at this moment in time, because we can start to do some of that stuff. I mean, think about it this way. What if the state were able to do a carve out for pharmaceuticals? And we remove all of the pharmacy benefit managers and all of these middle people. And we actually just do some direct contracting, and we get the drugs at a better cost, and we're able to provide them much more affordably to individuals who need those life-sustaining drugs. There are things like that that we can start to put in place that really do help build us towards eventually getting there. We understand we're not going to get there next session or even the session after that. But let's start figuring out and talking together about what we can do right now that'll make a difference in everybody's lives. Maybe a few people at a time, in a sense, because maybe it's not everybody in the, you know, commercial market right away. Maybe it's the folks in Medicaid and MinCare we start with, and then we move from there and bring more in. But there are ways for us to do this that gets us eventually there.
I agree with all that, and would underline that. And just a couple other thoughts I have is, one, again, I think about, we can do big things. We just did a whole list of big things. And so, we can do that. And I think about this a lot because the sort of that cynicism is, a tool or a tactic or a goal of folks on the other side, to sort of wear people down to the point of like, well, like, we can't do anything about it, so like we'll just stop trying. And so I think about that a lot, and I think one like antidote to that is a strong functioning government. Like that's a democracy issue. And so, for us and the legislature to continue to show that we can govern, we can get things done, which we are going to continue to do, I think helps with that sentiment.
That's great. Thank you. Okay. Well, I'm thinking to keep us on time, sadly. We're going to have to wrap up the questions at this point. But again, just listening to you guys so passionate on this, it just reinforces why it's so important for us to remain involved and aware and engaged with this issue, because that's the only way something's going to happen. So I think at this point, then what I'm going to do is, Rose, I'm going to turn it back to you, because we're going to move into action. Like, how can we remain engaged with this, and how can we stay involved? So, Rose, do you want to go back and
Yes.
share the deck?
Let me see if I can do that and go to this one. I'm assuming everyone, are you seeing the slide this time?
We
All right,
are.
I really do apologize for that. I don't know how that happens, but so I said earlier that we're looking at creating a campaign to win, and it's a long-term campaign. And, people would ask, well, why should we do a campaign on this particular issue? Because the status quo is literally killing us. We have to change this. We just can't continue anymore. So we want to make sure that the campaign is really easy to plug into, that any of our partners in this campaign can see this as a vehicle to build organizational power themselves through a statewide campaign campaign that really reaches, beyond the boundaries of just the Twin Cities area. We want this to be all encompassing, right? This means the disability community, the LGBTQ community. We want to make sure that organizations of color are represented and helping us fight women's reproductive rights. All of those organizations have a place in this campaign because health is the issue of intersectionality across the justice movement. And the campaign we will look for it to have a really concrete focus that will define what the concept is, what those building blocks look like for a pathway. And we can take a look at what we just were talking about that was just passed. How do we make sure that what's coming out of those studies and everything is really usable and good information that moves us on to the next level, which is to really care for patients and providers. Let me see, there we go. So think about it this way. We've got that 2023 legislation, right? That was passed that we just talked about, the deprivatization, the cost studies, administrative costs, the public option. And then we've got the 2024 legislative session coming up. So thinking about how those two intertwine, is there more work that needs to be done? What is that public option study going to look like? That's going to be important because just saying to take MinCare and expand it, please, everybody needs to know Minnesota Care is not public. It is a privatized program now. And so it's awfully important that if the DHS is going to bring to the legislature public options, one of them better be actually public, right? Totally public. So we're really pressing DHS and Commerce to make sure that one of those are public. You all can help put that pressure on as well. There are a couple campaigns we can plug into. We don't have to recreate the wheel here. There is a national campaign by People's Action going on called Care Over Cost. They are finding patients who are getting denials of claims. And they are doing two things with that information and with that patient. One, they're helping the patient fight back. Those appeal processes, when you get claims denials, if any of you have experienced this, it is incredibly burdensome and cumbersome, and it is built that way purposefully so you won't go through the appeal process. The People's Actions folk have actually got free of charge pro bono attorneys and social workers who are helping people fight back to get the care that their provider has prescribed for them to get. At the same time, they're taking that story and making it public, and they are putting it literally at the doorstep of the insurance company that tried to deny that human being the care that they needed. Stay tuned, because we're hearing that they're going to want to do a big action sometime in February or March in our backyard at United Health. So we'll make sure you all know about that when that comes together, where it's just in the planning phases right now. But we can plug into this. We don't have to recreate the wheel. Then the nurses, the National Nurses United, they have a campaign called Patients Before Profits. We are going into another campaign season. For those who can work on and like to work on electoral politics, what the nurses are saying is we should get our candidates to pledge not to take money from the industry so that they can purely be looking straight at what is in the best interest of the patients and the providers themselves. So those are campaigns that are ripe and ready for us to jump right on into. So if you're ready to get to work, one of the ways that you can work with us as we try to create the campaign, because we don't have it done yet, we're trying to put those pieces together. We need folks like you to help us figure out some of those pieces. You can join as a member, as an individual. You can come and join Healthcare for All Minnesota. You can be a representative of an Indivisible group or, another organization if you want to, and join our Health Justice Allies, which is a group of unions and faith-based and community organizations that are working together to try to figure out how we're going to put this campaign together and make it work. We've got all kinds of committees. If you like education, if you like the policy work, if you want to make sure that we're being inclusive and everybody means everybody, fundraising, organizing, whether that's coalition building or whether that's base building with individuals and going out to the state fair and Pride Fest, we've got a place for you. So this work is important. Join us in it. there's all kinds of opportunities for you. And if you think that it makes sense to keep this conversation going, reach out, let us know. We got all kinds of us that would love to come and talk to a community group that maybe you're part of, or maybe it is a community event that's going on. Sponsor a house party, talk to your neighbors about just how's healthcare working or not working for them, and how would they like to see the system actually operate. And let's tell them that we can actually make that happen for them, and they can join us in helping us do that.
Wonderful, wonderful. Can we slide to the next one as well?
Oh, I'm sorry. That's just my contact information. You all will get the slides as they said. So I think was I going to here?
Yes, you were going
Okay,
to.
there you go. Go ahead.
So we are encouraging people. You heard Senator Boldon speak about this study, and that she's a little bit concerned that perhaps it is not going to capture accurately everything it needs to capture, so we get a sense of true cost. So this is going to be a call to action. Again, you don't need to feel like you got to read all these details right now. It will be sent out to you in a PDF, and we're asking you to pick up the phone now. Don't wait till February. Pick up the phone now, or email if you're not comfortable being on the phone, and call your House rep, call your state senator. And basically we're saying, please make sure that these reports and studies are accurately capturing the data that should be truly reflected. So it gives you a lot of very specific things. You can review it, and then you can do it in your own time. I want to do something because I hadn't really planned on this, but we have heard from two powerhouse individuals talking about this issue in, I'll just say for myself, a compelling way. And so I'm going to invite everybody right now in this moment in the chat, put an adjective in. How are you feeling as we kind of move to wrap this meeting up? And while you're doing that, let's kind of do a virtual round of applause for our speakers for taking time out of their lives to join us this evening. They were amazing. And I want to kind of circle back, both Rose and Senator Boldon talked about this being a movement and this being a heavy lift. And I want to remind people about 2023, because you had paid family medical leave pass. That was a 10+ year journey. That was 10+ years of work by activists, advocates, gathering stories. You had driver's licenses for all. Again, another decade plus effort, and it happened. So when we raise our voice and frankly vote for people who support these efforts, this is the kind of thing that can happen. And we're hoping all of you remain engaged on this issue. You can remain engaged via Edina, Indivisible St. Paul. We will be following these issues. Obviously, you can follow Healthcare for All, Minnesota, and just remain involved and informed on this issue. I want to move to one more thing as we sort of wrap on this. And it is a poem that Rose was gracious enough to allow us to sort of close on. So I'm going to just share this with people because it's beautiful. The system will collapse if we refuse to buy what they are selling. Their ideas, their version of history, their wars, their weapons, their notion of what is inevitable. Remember this: we be many and they be few. They need us more than we need them. Another world is not only possible, she is on her way. On a quiet day, I can hear her breathing. This is what we have to sustain, because Senator Boldon and Rose both spoke to, they want to wear us down. They want us to be fatigued. They want to make it complicated, so we give up. And I am loving the adjectives people shared in here. They are determined, inspired, hopeful, and excited. Hell-bent. Yes, yes, I love it. So I want to just thank everybody. Any closing thoughts by Senator Boldon or by Rose?
I just want to say again, a thank you. It is, for me, there's a lot in the world to be, discouraged by or down by, but for me, the antidote for despair is action. And so I am grateful to be in joyful action with all of you.
And we with you.
Yes,
Anything?
thank you, everybody, for being here tonight. This is how we make this happen. It is in, having opportunities like this, just to be with one another in this space together, share these stories, talk, and be hopeful. That other world is possible. And I too can hear her breathing, and am very, very, very grateful to be in this movement with all of you. Si se puede, everybody.
Yes. Thank you, everybody. And keep showing up for these events. This is how we all learn together. We don't have to be experts. We just have to remain engaged. So thank you, everybody.